Hello, and thank you for joining us for another episode of Matters of the Heart, a program brought to you by Haverhill Community Television as well as Pentucket Medical Cardiology. My name is Dr. Srivastava, a cardiologist at Pentucket Medical here in Haverhill, and I'm joined today by my colleague, Dr. Seth Bilazarian, also a cardiologist here in Haverhill, and today we're going to talk about something that I think is pretty exciting as it represents a new treatment modality or possible new treatment modality for something that in the past has always been treated with a big major open heart surgery. And that's a catheter-based approach to fixing aortic valve problems, specifically aortic stenosis. And so with that, I will hand it over to Dr. Bilazarian so he can get started on the talk.
Yeah, I'd love to. Thank you very much. So, as you said very well, there's this heart valve problem. It's what doctors call an acquired heart valve problem. It's not a heart valve problem that we're born with. Those are called congenital heart valve problems. But an acquired heart valve problem is something that happens over the years. Commonly happens in people in their 70s and 80s, this heart valve problem called aortic stenosis. So that's what we're talking about today. It's a narrowing of the main outlet valve of the heart. So when this outlet valve becomes narrowed, the heart can't push blood out, even though the heart may be functioning completely well. It just is narrowed so much that blood can't come out as well as it normally does. It puts stress on the heart, and ultimately the heart can fail if it's left without treatment. And as you said very well, the aortic valve treatment has always been with surgery only, but we now have a second paper that has been published just very recently in the New England Journal of Medicine of a trial that has been done in many centers around the US and in Canada, looking at using a catheter-based treatment either from the groin, like a heart catheterization, or from a small incision in the chest, rather than the big incision called a sternotomy, which is cutting the whole central chest to replace the heart valve. And this heart valve technique was shown previously. The more recent study we're going to talk about today, but the prior study, to very shortly summarize, looked at patients who surgeons said, we cannot operate.
So too sick with other things?
Too sick. Patients had severe lung disease, had other issues that they could not take on the surgery because the surgeons felt that their risk was too high. So that other study, the one that we're not talking about today, looked at those patients, and those patients at 1 year, if they were randomly assigned, half of the patients were just treated with medicine, they didn't get any treatment, and half got this catheter treatment. And the patients that didn't get any treatment at 1 year, 50% of them were dead at 1 year. So very serious problem. Half of them are dead at 1 year. You know, rates that are higher than the most serious illnesses we think about, AIDS, cancer. Those diseases don't kill 50% of people at 1 year. So when patients have this problem, they have a severe aortic valve narrowing and they have symptoms from it. Those are the people we're talking about. If they can't get surgery and they have that problem, a severe problem, they have a 50% chance of dying at 1 year. If they got this catheter-based treatment, their death rate at 1 year was 25%. So it reduced it in half. So only 1 out of 2 were living at the end of 1 year if they didn't get it. 3 out of 4 were living at the end of 1 year if they did get it. So that's really what we're talking about is this treatment. It's called transcutaneous aortic valve implantation, or TAVI, T-A-V-I. So that's really what we're talking about today. And we're talking about the most recent study, which was the first time people who could have surgery were randomly assigned to either get surgery, the traditional way to do this, or get the catheter-based treatment. And this is called the PARTNER trial, P-A-R-T-N-E-R. And the PARTNER study was a study looking at this approach to using catheter treatments for this particular therapy.
So let's go through this trial a little bit, just so people can understand a little bit more about how trials are done. How many patients were involved in this, roughly?
So this trial was done from 2007 to 2009. Yeah. When you and I look at studies, we always want to say, was it done in recent times? You know, if it was done 30 years ago, it's harder to know whether it was something that's meaningful for us. So very recently done. It was enrolled 699 patients. And these patients were first divided into whether they could have the procedure done from the groin or whether they had to have it done from the heart direct approach. And the direct approach is making a very tiny keyhole, and through the keyhole, this catheter is put in. So and the difference between those two is if you don't have arteries that are big enough to put the catheter from the leg, you would then be randomly assigned. You would be assigned to getting it from the heart. And then once that division was made, half of each group got either surgery or the catheter-based treatment. So I would say that the study design was a very good one. You couldn't be in the study if you didn't have severe aortic valve narrowing, of course. Sure. And you couldn't be in it if you needed artery treatment as well. If you needed bypass off, you couldn't be in it. You couldn't be in it if you had other valve problems. So basically, it was a study that was actually very good and very reasonable the way they approached it.
Seems very realistic to
Exactly right.
real day practice.
Exactly right. So our practice, we sent several patients for this trial. A couple of the patients were actually in their 90s, and actually they were randomly assigned to the surgical arm and not to the catheter arm. So that's the way these studies work. Basically, we're going to talk a little bit more about how the treatment goes, but maybe actually it would be good to talk about right now. So first, if we could show one of the first still frames that we have, if we could. Okay, we could show this. So this is actually a picture of a patient that had this procedure. So this is the first part of it. So I'll just step through this a little bit. This was actually a procedure done on the father of one of our associates. This is a procedure of one of the two main valves that are being done, and I'll just review what's being done. The catheter that swings, that's sort of down the bottom, that's got two little black marks on the end of it, that's a pacemaker catheter. That's a pacemaker put in the heart to actually rapidly pace the heart during the procedure. The other catheter that's in the middle of it that has dye coming out of, you can see the black dye filling the aorta, is called the pigtail catheter. So this first picture is a picture of the catheter in the main aorta, and it's resting right on top of that severely narrowed heart valve. And you can see a little bit of dye going into one of the arteries of the heart that's going out across the right. So that's the first setup picture of this. We'll go to the next picture. We'll just go through all these pictures together and look at how the procedure is done. This next picture is a picture of the balloon actually stretching out the heart valve. So that big balloon is actually being placed inside the heart valve and actually ripping open the severely narrowed valve. This is called a balloon valvuloplasty. And this procedure has been done in the past to try to treat patients who couldn't have the surgery. And it does open up the valve a little bit, but it's not very durable at all. It lasts only a few months. So this has really been abandoned as an approach to the treatment of this problem. But it's done as part of the procedure to open up the valve initially. We'll go to the next picture. The next picture is actually the valve being put in. And you can see the valve is now being positioned in the heart.
So what exactly are we looking at there?
So we see two things. We see one curlicue catheter on the right. That's called the pigtail catheter. And you can see the dye is being injected to see if the catheter is at the right position. And the other catheter next to it is a long, thin metal stripe. And that's the heart valve inside of the stented stent. That's the actual apparatus of the stent. And what's going to be done is, you'll see this in the next pictures, we'll go to the next picture, is the stent actually being put in and actually being stretched out. So here's the stent actually initially being put in. So part of that stent is inside the heart, and the other part is outside the heart. So this is going to be done.
That's what looks like a upside down badminton birdie thing. That's what the
yes, exactly. So that's it. So that's the stent deployment system. And we're going to see it pulled back a little bit more in the next picture. We'll go to the next picture. So there's three steps here you see were filmed. So this is the next picture. The stent is being pulled back a little bit more. You can see that the cage is open a little bit more. If you can play that again, please. So you can see the cage is opened up a little bit more. The stent is halfway open. And this is, again, assessed to see whether it's in the right spot. And we'll go one more time to the last step. And this is the last step of the catheter actually fully deployed in the artery, so in this aorta. So you can see it looks like it's got a funnel at the top that's a little bit bigger, and the valve is inside that. So we now we've basically ripped the valve open that was severely narrowed, and a new stent that's got a valve inside has been placed inside the heart, and the catheter dye is injected to see whether that is in a good place, and that's it. So that's really a picture of one of the two heart valve systems. One of the heart valve systems, the one we just saw, is called a self-expanding system. That system is enclosed inside with a metal, it's called nitinol, that springs into position as soon as it's allowed to. So there's a covering over it, and as soon as it's removed, that stent expands and is inside the artery. That's one of the systems, a self-expanding one. The one that we're talking about today is one that's balloon expandable. It's like the kind of stents that we use in arteries. There is a balloon inside of it. It stretches out, and the balloon stretches the metal, really just plain stainless steel, to be pushed against the wall of the artery. So that's really the two kinds of stents that are really very rapidly evolving right now.
I'm not sure where to jump with this next, whether, because I have a lot of questions about how it's done, what the recovery is like post-procedure, what the complications are, the risks? I mean, is this an appropriate time to ask about that
Well, I
type
think
of
we're going to
stuff?
see that as results of the study, because the best answer to those questions, they're great questions, the questions our patients ask.
Right.
Well, let's rely on the data from the study to say exactly what the study said.
Yeah, so maybe you can tell us what the results of the study were.
Okay,
What did it show?
we'll just review briefly. You know, the study allowed people to be in the study if they, as I described, if they had the severe aortic valve narrowing and they didn't have any of those other issues like other valve problems or needing other artery issues. And the other criteria was they had to have a valve opening that was big enough to accept one of these stents. It couldn't be too small or too big, because they only make them in certain sizes. So pretty practical but reasonable things. The study design, as I described, is if you could have the stent put in from your leg, you would put in that group. If you couldn't, you would put in the group that was put in directly in the heart. You were assigned to one of those two groups, and then half of the patients got surgery, randomly assigned, and half got the catheter treatment. The primary endpoint was death at 1 year. I told you in the last study, if you didn't get one of these valves and needed it, your death rate was 50%. If you got the catheter treatment, your death rate was 25%. So it's not perfect,
right.
Still a serious problem, but it was a big improvement. In this particular study, what they did was they found that 244 of the patients in this study got it from the leg, and 104 got it from the heart. So 2/3, 1/3 sort of split of this whole thing. The patients who had to get it from the heart direction, that's called transapical, because the heart point where they put it is called the apex of the heart, so it's called transapical.
Can you just, I'm sorry, can you just explain for the audience a little more what really happened? So they're going in from right here.
So sort of underneath the nipple of a man, you know, a woman's breasts affect this a little bit, but underneath a man's nipple, approximately on the chest wall, a small incision is made between two of the ribs, about the size of a silver dollar, and then a hole is made in the heart, and through that the catheter is placed for the valve. So that's the transapical method. The transfemoral method is the one that I just shown. Catheters are put in from the groin area and go up to the heart, and the catheter is put through the arteries. So those are the two methods. Thank you for reviewing that. So just to skip to the results, basically the results here were that the transfemoral patients, the patients that got the catheter put in from the groin area, the rate of death from any cause at 30 days was 3.3%. So 3% of the patients died at 30 days, and the patients who had surgery, 6% of the patients died at 30 days. So these rates seemed better for the catheter-based treatment than for the surgical treatment. But when you look out at so then I'll just compare those to the ones that were done from the transapical method. The rates were 3.7% for the catheter treatment, or 8% death rate at 30 days with the surgical approach. When you look out further than that, at 1 year, the rate of death from any cause in the patients who had the transcatheter treatment was 24% at 1 year, and with surgery it was 26%. And that's right in line with what I told you the other study showed, 25% 1 year death rate in the study that patients who couldn't have surgery at all. So sort of very consistent findings that the 1 year death rate for these patients are often very older, have a lot of other issues, lung disease, kidney issues, other issues. These rates show, you know, good 30-year rates, but patients often are dying of other issues even out at 1 year. The comment was made in the study that there's a prediction that we can use, and we use this in our office, that the Society of Thoracic Surgeons, the people who do this surgery, the open heart surgeons, the bypass surgeons, the valve surgeons, that group, have come up with a scoring system, and people can go on the web, they can go to the STS score, and they can actually put in their own data for age, sex, different heart problems, and there's a prediction. And in this study, the STS score predicted a 30-day death rate would be 11%, and the actual rate was much lower at 8%. So they did better than what was predicted for surgery based on the scoring system that's used commonly to predict events in this problem.
So if you could just give one quick summary statement about how the transcatheter approach compares to a surgery approach. Is it better, equal, the same?
Well, if you look at only the primary endpoint, death, which is of course very important, but it isn't the whole story.
Sure.
The death rate looks like they're equivalent at 1 year. But of course, there's less to do to going through a catheter-based treatment than a surgical treatment. The recovery time is much less. So that would favor that. We're going to talk a little bit more about it. So let's go ahead and talk about some of the knocks on this. catheter-based treatment. And that's one of the biggest things is strokes. So let's talk a little bit about strokes. Now, of course, nobody wants a stroke. But certainly nobody wants a major stroke. A major stroke would be something that people would familiarize themselves with, would be really significant disability. So can't speak, can't walk, or has real weakness on one side. So a major disabling stroke or a major stroke would be something that's really important. But just to talk about the stroke rates, because strokes can happen in surgery or in any kind of catheter treatment, the kind of catheter treatments that I do, the angioplasty, stroke is a known risk. The stroke rates for these catheter-based treatments at 30 days was 5.5% for the catheter treatment and 2% for the surgical treatment for any kind of stroke, whether a mild stroke or a TIA where you had a little bit of problem and then it went away within 24 hours. Anything like that, the rate was 5.5% versus 2.4% at 30 days. And at 1 year, it was 8% for the catheter treatment and 4% for the surgical patients. So a doubling of stroke risk. So the same death rate, but a doubling of stroke risk in the catheter treatment. But that's all strokes, and it's not that we don't care about all strokes, but let's drill down a little bit more to major strokes. And the major stroke events were still concerning for the catheter treatment. It was 3.8% for the catheter treatment and 2.1% for surgery. But if you look at it 1 year, something I'm very concerned about that we have to sort of figure out before we really start recommending this, is that the stroke rate rose from 3.8% at 30 days for the catheter treatment, but rose up to 5.1% at 1 year. So one of the things that we like in any treatment is, you get through the hazard, the risk of the initial procedure, and then you should be out of the woods. But it doesn't appear to be the case with this catheter treatment. There's some theories about that. We could talk about it. But with the surgical treatment, it was 2.1% at 30 days. You took your hit. But at 1 year, it's 2.4%, almost the same, no real difference. Sure. So when you look at 1 year, the stroke rate for the catheter treatment was 5.1%, and for the surgery, it was 2.4%, about a doubling of major stroke. So I think that's an important thing. So you ask the question, and patients are going to ask, and that's what we're here to talk about. Right. Which is better? What does it mean? Well, death equal. Stroke worse, and including major stroke. Still low rates. I mean, we don't want to knock this completely. Yeah. The stroke rate was 5.4% at 1 year. Major strokes, that's 1 in 20 patients have a major stroke at 1 year with a catheter treatment. Okay?
How about, well, maybe you have an order you want to go in here, but how about recovery, post-procedure?
Yeah,
so
well,
post-surgery, post...
I do. Let's talk about that. But one thing that they looked at is, we and I always look at the subgroups. Okay. Yeah. Like, what about different groups? Men, women, older people, or certain racial groups? What are the differences? And there are some subgroups that were suggestive to be better. And the two subgroups that seem to have a better event rate were patients who were women and patients who had a prior bypass surgery. They seem to have better events with the catheter. Now, I don't know why women, but one theory I would think with the surgical thing is that if you've already had a surgery, having another surgery has a lot of risks associated with it. So you could think that might be a reason I could rationalize. I'm not saying I know, but that rationalize why surgical, prior bypass surgery might be a benefit for catheter treatment. Why women, I don't have an answer for. Okay. So moving on, let's talk about some other clinical outcomes. You were excited to hear some other stuff, but let's review some of those other things. At 30 days, the transcatheter group had significantly higher problems with bleeding from the vascular site. So you're putting these very, very large catheters. These catheters are 5 times larger than what we use for a heart catheterization. So that's a big thing. So of course when they're taken out, there could be injury, there could be bleeding. So vascular complications were higher with the catheter treatment than with surgery. With surgery there's no vascular accidents, so the risk is very low. So 11% versus 3% for surgery. So higher vascular complications. So the site you go in, higher risk. But there was much more major bleeding with surgery than there was with the catheter. There's a risk of having to be taken back with surgery because one of the sites are oozing or there's some kind of risk of bleeding. With surgery, that rate for surgery was almost 20%, and it was 9% for the catheter treatment, so more major bleeding. And then there was a higher rates of this irregular heart rhythm we've talked about on the show before called atrial fibrillation. With surgery, that rate was 16%. It was only 8% with catheter. So a doubling of the atrial fibrillation rate and a doubling of the major bleeding rate with surgery compared to this catheter treatment, but more vascular risks, 11% versus 3% with the catheter treatments.
It's interesting. I'm just thinking on a tangent here that increased atrial fibrillation risk with surgery. You would think there'd be a higher stroke risk with that because of the link between atrial fibrillation and stroke, but that didn't bear out so much.
But of course, you could also argue contrary, that all those patients who got atrial fibrillation were treated with Coumadin, and maybe Coumadin is a link here to help prevent patients from stroke, because the treatment for the catheter treatment was only aspirin and Plavix.
That's going to be one of my questions to ask you post.
For 1 year, aspirin and Plavix, but for surgery, aspirin only, no Plavix. So that's a difference. So I want to get a little bit further to drill down to some of the other questions you asked. At 30 days, the patients who had the catheter treatment had more improvement in how they felt. More of them were at the class 2 level, which is just mild symptoms, than the patients with surgery, which is another thing. You know, patients take more than a month to recover. My patient that was in this trial who had surgery was 90 years old, took almost 8 months to really fully recover. It just took a long time to recover. I mean, he did well. He was alive at 1 year to meet that criteria, but it took a really long time to recover. It's a big surgery to recover from. Some other issues to talk about is one of the things that you asked about. The patients who got the catheter treatment, they only spent on average 3 days in the intensive care unit, but patients who had the surgery spent 5 days on average. And the patients who had the catheter treatment spent a total of, on average, 8 days in the hospital. The patients who had surgery spent 12 days in the hospital. So 4 days less for the catheter treatment than for surgery. So those are some important, I think, clinical things that you asked about these things. So let's moving on, and you know, we still aren't going to be able to answer the questions about whether this is all, you know, which way to go here. But I would just say a brief summary is that that this data seems to suggest that we can say that there's good results and relative equivalence. The statistical or research term is non-inferiority, that the standard of care was surgery, and they were testing to see whether the catheter was non-inferior, sort of fancy doctor speak for saying it's as good as the surgery, and that seems to be the case on the most important thing of being alive. But there's plenty to argue about where to go in terms of these two things. And the editorial for this paper in the New England Journal was written by a surgeon at the Mayo Clinic, and I thought he did a good job sort of summarizing things. And many of the stroke things were sort of handled in this, and I'd be interested in hearing what you to say. But he highlighted the thing that we said, that there's a doubling in the rate of the neurologic events and the major stroke with this procedure compared to it. And there's plenty to support this. There's trials actually have looked at even just doing a heart catheterization, not even this procedure, looking at just crossing the valve with a catheter. And if you do MRIs on these patients, as many as 20% of these patients have a new area. It looks like a tiny stroke that they didn't even know about. So there's a lot of risk of these little plaques going off and going up into the brain. So the idea of going in and ripping it apart with the balloon like we showed on our picture, rather than going in with a surgeon and cutting it out, you think could be. But one of the challenges that I think that will be improved is that there are some techniques to protect the brain from this. And there's actually a company has come up with an umbrella that can be put in from the arm that goes up and covers over all of the vessels going to the brain, so that there's a screen that will filter out anything that would go up to the brain, so it won't go up to the brain, it will go down to the legs or somewhere else, less dangerous.
And this is temporary during the procedure?
Right, temporary during the procedure. So the umbrella would be put up, a protection device it's called, left up during the procedure, and then taken down at the end of the procedure. So it's an exciting, not proven yet, but that might reduce the procedural rate. But what people are wondering, including me, is why did it go up from the 30-day to the 12-month? And that's very concerning. Right. So we don't have answers yet about that. People have theorized that maybe there's like areas around the around the stent, that are little areas that can collect clot, and those collection of clot might go to the brain over the ensuing months. Unknown, but that's a theory. And the last thing that we don't know, and I think that we still have to be concerned about, is the durability of this. Is this stent going to last the 10, 15, or even 20 years that we're currently seeing surgical valves last? Right. So those are all issues that I think are excellent questions, but we don't have answers
2007, for. So far we have just 4 years of follow-up data?
Well, we have data longer from other countries, but for this trial in the U.S., 2007 to 2009, yes. Okay. So these are the questions. So where are we now? And I'm interested in what now that you've heard this, I know you're familiar with this data, but I don't think that we should recommend this for all. But for high-risk patients, I think this is an exciting alternative.
Right, so that was going to lead me to where are we? today, if I have a patient walk into my office who wants this or somehow fits the, can they get it done, or is it still part of a trial? How does this work
right now? As of this day, so our date today is June 8th of our filming 2011, we only have availability in patients who are high risk. So, but we expect that the FDA will approve it for high risk in the future, and we hope that this will be available for high risk patients, because this trial was done in high risk patients, and based on the strength of this data, we hope that it will become available for our patients.
Great. And where are places around here doing this procedure right now? Or?
Well, currently in eastern Massachusetts, the sites that are doing this particular study that was highlighted today are Mass General and the Brigham. The film that I showed you is for a different competing technology that's also very mature. That's being done at Beth Israel in Boston. So those are the local area hospitals that are doing this procedure. Okay,
well, great. Well, I thank you for what for me was a very educational review of something that's pretty new and exciting, and I like to think it can offer us some options for, as you said, the high-risk patients going down the road who otherwise are really left with not much else that can be done, because as you know, and as I think our viewers have learned, that there are no real great medicines for this condition. So thank you for that review. And I think with that, we'll wrap this up. This was another program of Matters of the Heart, brought to you by Pentucket Medical Cardiology as well as Haverhill Community Television. Thank you for joining us.